Anybody?
The tumor pressing on the spine.
Not the spine. The spinal cord. It's a difference. Subtle, but a difference. Okay.
Car accident,
Excuse me?
maybe like a car accident, you broke a bone and that's compressing the spinal cord.
Yeah, that could be, but normally it's a tumor. That normally what it is a tumor which has spread to the bone. And it has gone through the bone and is either pressing or is going into the cord. So here is an MRI. And you can see here's the cord running down the middle here. This is one of the vertebrae. Here's another one, another one, another one, another one, another one, all the way down. This is a compressed cord. So you see here's the cord, the black is the cord. So you can see that the tumor is actually invading into the cord. That is a true spinal cord compression. What do you think that would do to the patient? What kind of symptoms may the patient have? Paralysis, yes. Hopefully we get them before they get to that stage. So what do you think the early ones would be? What do you think the early symptoms might be?
Tingling.
Tingling in the extremities, yeah. And maybe their legs going away from them, or they lose control of their hands or their arms, depending on where the cord is impinged. Okay, depending on where the cord is at. So here you see that it is, the cord comes down here. So this is lumbar vertebra. So where would that be? So the lumbar vertebra, what part of the body would lose sensation if it was a lumbar vertebra? Pardon? Lower part, yeah, lower half. That would eventually, if we don't do anything, end up with the patient being paraplegic. And if it was a little bit above, maybe in the thoracic region, it could still be paraplegic. What if it's up here? What if it's the C-spine?
Arms.
Mm-hmm.
Lower. I don't know. Up there, it seems like it's so much more. The higher up it is, it would seem like it would be okay.
Yeah.
I think.
If you have a patient who is a spinal cord compression, either upper thoracic or lower cervical spine, it can end up with the patient being quadriplegic. Everybody knows what that means, right? Basically paralyzed from the neck down. So that's what we're trying to avoid. The idea is to get those patients before they reach paraplegia. So it is an emergency. It is totally, there are only 2 or 3 things that are actually a radiation therapy emergency. This is one of them. This is something that you would get called in on the weekend to treat. There's not an awful lot of things that you get called in as an emergency, but this is one of them. So patients unnecessarily, unfortunately, it is under-recognized. The patients can, the old saying is, that the patient stays on the nursing unit for a week, and then on Friday afternoon, people panic because they know that the therapy department doesn't work on weekends. So you get these emergencies at 3 o'clock on a Friday afternoon. It's the old joke, but it sometimes happens that way. So patients unnecessarily left paraplegic as early symptoms and signs are not recognized by the doctors on the ward, on the units. Remember, doctors who do not usually treat cancer patients are, for want of a better word, ignorant of our field. They don't know what we do. Most of them don't really want to know what we do. So you get everybody's heard the word hospitalist. Does anybody not know what a hospitalist is? Okay, a hospitalist is a physician who basically is a generalist, but he works in a hospital. So he's the guy that is on the nursing unit to treat patients. He is not a specialist in any field at all, but he works as a routine in the hospital units. He's the one that sees everybody. So here's the symptoms. 95% of the patients have pain.
What's Scottish audit?
It was an audit done on Scottish patients.
Simple enough.
I know it sounds simple, but that's what it
Is
was.
that a medical
It
term
was-
we don't know?
It was a clinical trial done in hospital, in the Scottish hospitals, and that's what they come up with, and that's why it's called the Scottish audit. So, anyway, 85% pain, 85% weakness, and look at the duration, 20 days, that's the mean. So, the patient has been experiencing weakness in whichever limbs for a median of 20 days. So some would be more, some would be less. Only 18% walking at time of diagnosis. So they're either in a wheelchair or they're on a gurney. If they're on a gurney, there's not a lot you can do. 68% have altered sensation, whether that's in their fingers or toes or knees or elbows or whatever. 56% have urinary problems. If the patient has some kind of weakness, that can also mean that they may have urinary incontinence. However, 74% have bowel problems, but some of them are on strong opioids. And what does that do? Painkillers. They what?
Stop you.
Yeah, they stop you. They make you, They make you constipated. Any kind of painkillers will make you constipated if you take enough of them. But opioids are really known for that. Normally when they give people opioids, they give them stool softeners and stuff like that to help them. But then you have 5% of those have fecal incontinence. So some of them may have urinary incontinence and then you have the fecal incontinence as well, which is not a very pretty thing to have. So pain in spine, 80%. Worse on coughing or straining. and frequently associated with reticular pain. Reticular pain is sometimes called referred pain. And what that means is that they feel pain in places that's not the actual thing giving them the pain. So you can have pain in your back, but the patient may feel it around here, but it's actually coming from the back, but they don't feel pain in the back, they feel it around this area. And it can be burning pain, hypersensitivity, so that the slightest touch, they can feel pain. And it precedes what they call weakness. So a lot of these patients are in wheelchairs because their legs keep going from under them. What we're trying to do with the treatment is to stop them getting as far as paraplegic. So bilateral or unilateral weakness. So light touch, pinprick. So have you ever been to the doctor and he puts a pin in your bottom of your foot to see if you can feel it? It's a neurosurgical thing. So if you close your eyes and he puts a pin in your finger, you have to tell him which finger it is. Or the same on the foot. That's the sensory change you're looking for. And then you may have change in bladder or bowel. So the bladder could be retention, or it could be incontinence. Change in bowels, it could be constipation, or it could be the other side. Oops, sorry. So we want, supposedly, an urgent MRI of the spine. And you see what we saw at the beginning. You can do a chest X-ray or a plain X-ray. That won't show you much of the spine or the cord. Bone scan won't show you much of the cord. They'll show you the destruction of the bone, but they won't show you the cord. So, immediate dexamethasone is a holding measure. So it says 16 milligrams IV stat, then 4 milligrams QDS PO with PPI cover. Okay, so, and it says aim to reduce vasogenic edema. Ignore the spelling, that is the correct spelling of edema. At least, as far as British is concerned, that's the right spelling of edema. So, what is dexamethasone? Anybody know? If I told you another name for it was Decadron, does that ring a bell anywhere? Okay. I'll give you another clue. It's something that some bodybuilders use.
Steroids.
Thank you. Why did I know
I
that
didn't
somebody would get
it was
that?
up there, I was like, is she looking for steroids?
Yeah, so
Okay.
dexamethasone is a steroid. And we use it to reduce edema, or we use it to reduce swelling in either the brain or the spinal cord, spinal canal. So any patient who has a brain tumor or a tumor in the spinal column will be on dexamethasone or Decadron. So In this case, they're gonna start with an IV of 16 milligrams, and then 4 milligrams QDS PO. So what does 4 milligrams QDS PO stand for?
4 times a day by mouth.
4 milligrams 4 times a day by mouth, yes. Good. So, radiation therapy, as it says, the mainstay of treatment. This is normal. So then once it has been certified by MRI or whatever it happens to be, the nursing unit will start them on IV Decadron, and then start them on Decadron by mouth. For treatment, you notice it says UK and the US. So in the UK, it usually is given 20 gray in 5 treatments. That's 2000 centigrade over 5 days. In the US, it's 3000 centigrades in 10. So in one of the series, one of the clinical trials, approximately 33% improved and 20% deteriorated. Those patients whose motor function declined the slowest had the best outcome. So what they're saying is, if you have a patient whose general condition was very slow in changing, they have a better outcome. Those patients who deteriorated quite fast had a poorer outcome.
So is that saying that 47% had no change at all?
Say again?
Is that insinuating that 47% had no change at all? If approximately 33% improved, 20% deteriorated, what about the
Yeah.
other?
That's what it's saying.
So to me, that looks like that's not a.
Well, it depends on what condition the patients were to start with. If the patients were paraplegic or quadriplegic, there's nothing anyone can do to reverse the paraplegia. We try, but there's very little we can do. Sometimes we're lucky in that they can start moving their legs again or their arms again, but once it gets to the stage of paraplegia, there's not an awful lot that can be done.
And it could be a benign tumor as well, right? It's not necessarily.
It could be, it's not often, but it could be.
So do they get relief right away? I mean, it looks like 10 days, 10 days worth of treatment. So do you feel relief right away?
No,
No.
no.
So they're paying for some time.
Well, within the 10 days, they'll see some relief, but it won't be immediate because remember, the treatment is a delayed action. So what you're seeing on the first week of treatment, what you're giving in the first week of treatment, you don't see the results till 2 weeks after that. So the main effects may not be shown until a couple of weeks after the treatment is completed.
And the steroids they put them on initially, does that relieve them at all immediately or not?
It can, but the steroids have to be complete, they have to be continued for the duration of the treatment. And steroids is one of these things that you don't stop immediately. You have to wean people off. So if they have 4 milligrams 4 times a day, then You may drop it to 4 milligrams twice a day, and then drop it to 2 milligrams twice a day, and 1 milligram twice a day. And it goes on and on and on until they finally are off it completely. You do not stop steroids cold turkey. And the problem is that if you're doing the steroid weaning off, if they present with symptoms like a headache, you have to reverse it and go back up to your last dose till the headache goes away, and then start slowly weaning them off again. So it's really a difficult system. So this is what we normally do. Single posterior field. Patient usually supine. It would be great if we could do them prone, but in that situation with a patient who's either paraplegic or quadriplegic, getting them on the bed is good enough. If we have to treat them supine, then we treat them supine, and it's much easier because you cannot. It's more difficult to roll somebody when they have no feeling. It's very difficult to do that. So, single posterior field, abnormal area plus 1 or 2 vertebra. So, in this case, the abnormal area would probably be about here somewhere. So then you have 2 vertebrae on this side and 2 vertebrae on this side. And that's just to make sure that we haven't missed anything. You don't just go ahead and treat this little area here. You have to give a little bit more extra. And you should, and this is badly done because you should join it at the infravertebral disc. So it should be here or here or here. You always stop the field at the infraorbital or the infravertebral disc. Why is, go ahead.
Do emergency patients also good for planning?
Sometimes. If it's a real emergency and the patient the doctor gets called, say, early Saturday morning, they'll bring them in, they'll bring us in, and we'll treat. We'll look at the films that we have from MRI, and he'll say, okay, we need to center on T5, treat 2 above, 2 below, and do it. Do a film on do an image on the machine, but leave the planning till Monday. So, but if it's somebody that comes in on a Friday afternoon, then he may want to do planning, but it's an emergency plan. So it's one film, treatment is done, or planning is done, treatment is done, and they could be out of the department in 45 to an hour. So it really does depend on whether it's a real emergency over the weekend or something that happens at 4 o'clock on a Friday afternoon. So, no evidence, so a single vertebral region of involvement. No evidence of widespread metastasis. This is some things that you have to be looking at. They can't find any metastasis elsewhere. Radio-resistant primary, renal or sarcoma. In that case, you may want to give him a bigger dose. Previous treatment to site. So if he's already been treated to that site, that particular vertebra, you may have to think about that. Because you do not want, unless it's a dire emergency, you do not want to retreat a site. Unknown primary. It says get tissue. There is such a thing as an unknown primary. That may sound weird. Why does it sound weird? You tell me, why does it sound weird to have an unknown primary? What would I mean by an unknown primary?
Like the type of cell?
Sorry?
Like the type of cell that the tumor is?
Yeah. So if you have nodes, and they usually come up in the head and neck, and you know that it's cancer, but you can't tell where the primary is. So you do all the investigations. It's not a lung primary. It's not a head and neck primary. It's not nothing. It's counted an unknown primary. So you don't know where it's come from, but it's there. So you have to treat it. So they say, get a biopsy, if possible. If not possible, then you may want to treat it without the biopsy, which is very rare. So 75 to 100% improvements in pain. This is for surgery. Improvements in neurology in 50 to 75%. A lot of time you don't have time to do surgery on these patients. You want them treated immediately. So chemo, you can treat with chemo. Not very common, but you can. Lymphoma is very easy to treat because it is both radioresistant, very radiosensitive and chemosensitive. Teratoma and the small cell lung. So we may treat and then go to chemo. So it is very, very urgent when you have a spinal cord compression. Superior vena cava. Where would we get a superior vena cava obstruction from? This is another emergency that you might get called in for the weekend. So, what is this? Here's your vena cava, right? Superior vena cava obstruction. Think about where it is. What kind of tumor would likely cause a superior vena cava obstruction? Where would the tumor come from? Sorry, somebody say lung? Lung is correct. Or mediastinum. So obstruction of the flow of blood flow through the superior vena cava. Here's the superior vena cava. And you want to, obviously, you don't want this to have a problem. You see here, this is an obstruction. You have a nice nice superior vena cava, and then it goes weird. So there's something there. So here's what would work. So lung cancer. So it occurs in 10% of all small cell lung cancer cases, and in 1.7% of non-small cell lung cancer cases. So lung cancer, 80% of SVC obstructions are from lung cancer. 10% are from lymphoma. So those are the two biggies. 5% other malignancies and 5% benign cases like aneurysm or goiter. And it actually makes sense for the goiter because it's here. And it could easily do an obstruction. So symptoms: swelling of face, neck, one or both arms. Distended veins, shortness of breath, headache, or lethargy, and/or lethargy. But the most common are swelling of the face and neck, distended veins, and shortness of breath. Some of these patients cannot lie down. They certainly can't lie flat. So this isn't a very good one, but you can see, does everybody see the distended veins here, here, and here? So what that is the blood flow is supposed to go through the superior vena cava, but because it's obstructed, the veins are trying to find another way around. So there's distending all the other veins to get around the obstruction. So this is common in superior vena cava. Also, the neck is swollen, the arms are swollen, and actually this isn't quite as bad as some of them I've seen. The veins usually stick out quite a bit more. See this lady here? You see the swelling in her neck, and her face is all swollen, and her eyes are puffy. That is another sign of superior vena cava. So early stage, puffy neck, neck veins don't collapse, later distended neck and chest wall veins, and swollen face, neck, and arms. So what do we do with this? Well, we treat them. We treat the chest. So, main aim is to distinguish whether obstruction is a blockage from within, for example, a DVT. Everybody knows what that is, DVT, deep venous thrombosis, a foreign body, or a tumor in the actual vessel. Or without extrinsic compression from mass. So, speed of onset. It can be fast. It can be really fast. If the patient is becoming drowsy, then this is an emergency. Any risk factors, central line, any symptoms of cancer, especially lung cancer or lymphoma. If the patient comes into the ER, for example, this is the way it usually happens, comes into the ER and they have a history of lung cancer and the physician sees its distended veins. Hopefully, someone will figure out that there's something wrong and call the oncologist on call. Any other symptoms, local symptoms, pain or stridor? Anybody know what stridor is?
Breathing sounds, abnormal breathing sounds, like a wind tunnel.
Yeah. Remember, these patients, if they have lung cancer anyway, they're not in the best of shape. Any evidence of malignant disease elsewhere? So lymphadenopathy. Lymphadenopathy, anybody tell me what that is?
Disease of lymph organs, so lymph nodes and lymph system in general.
Enlarged lymph nodes. Hepatomegaly. Liver what? Enlarged liver, yeah. Or collapse or consolidation of the lungs. So if they have a lung collapse, then they really are in deep trouble. So, chest x-ray. Is there a mass? Oh yeah. Venogram, we probably wouldn't do a venogram these days, we'd do an MRI. Venogram. Fine node aspiration of the nodes and median stenoscopy, if you have a chance to do that is. If you can obtain tissue, that would be helpful. That would give you a chance to see whether it's a small cell lung cancer or a lymphoma. And why is that necessary? Well, small cell lung cancer, is it radiosensitive or radioresistant?
Sensitive.
Mm-hmm. What about lymphoma? That's very radiosensitive. So the chances of you reducing the obstruction if it's a lymphoma is a lot better than the chances of you reducing the swelling if it's a small cell lung cancer. So here's the tumor. Big one, huh? Let me just, please nobody fall asleep. Okay, so here's the tumor. And you notice that trachea is actually pushed to the right. So the tumor is pushing everything that way. And here's the lateral.
I think it's bigger than their heart.
It is, it can be, yeah. So it's pushing. And you can just see the carina, it's right there. But the carina also has been pushed a little bit. So here is the superior vena cava. This is all the tumor. You notice it's almost surrounding it. Here again, and again. So there's the superior vena cava. This is all different slices. So this is the superior vena cava when it starts off here. And as you go through the body, it gets smaller and smaller and smaller. This is all tumor. So we have to treat basically half a lung in order to treat this. So we can do several things here. thrombolysis, which means that they can try to stop the tumor by cutting off the blood supply. We can also do an anticoagulant with heparin, starting warfarin, steroids, no evidence to support them, chemo used for small cell lymphoma and teratoma. The response rate is 70%. Used for other malignant causes, radiation therapy, response rate around 60%. A stent, 95% response rate. It relieves the symptoms but doesn't treat the cause. So this may sound good. The stent, 95%, wow. But it doesn't do anything for the tumor. So the ideal would be put them on chemo and treat them. Now a lot of these patients are already on chemo because they're either small cell lung cancer patients or the lymphoma patients. And there's your stent. Again, it's not doing anything for the tumor. It's just making sure that the blood supply is not going to be stopped. It's a time to obtain tissue. You want to know what you're going to be treating. So if you don't have a confirmed diagnosis, you have to have some help.
How would you obtain tissues in that area?
If we have a patient who is a known small cell lung cancer patient or a known lymphoma patient, we wouldn't do anything about that. We would just go ahead and treat as if it was a SVC obstruction from small cell lung cancer. But if patient has no history of cancer at all, then you would have to do something like that. Bronchoscopy or mediastinoscopy and get a little from there. So lymphoma can be cured with chemo plus or minus radiation, and limited stage small cell can be cured with chemo radiation as well. Okay, I'm not gonna touch these ones because they're chemo based, and we wouldn't see them. So the other one would be, so we have spinal cord compression, we have a periovenic cable obstruction, and the other one would be a hemorrhage. Now we're not talking bleeding, we're talking hemorrhage. And there's two areas that would be as an emergency. One would be a bladder hemorrhage, and the other one would be a gynecological hemorrhage. So if you can imagine, if you have a patient who is a bladder patient, and he has a catheter and a catheter bag attached, and he comes down one day and his catheter bag is not the usual pale yellow that it usually is, which is urine. It's bright red. That would be what? What would you call that? What is bleeding from the bladder? Excuse me? Somebody?
Hematuria.
Hematuria, that's correct. Massive hematuria. And the same with gynecological. If you're passing blood via the vagina or the urethra or the rectum, for example, and it's bad enough to be called a hemorrhage, then that is an emergency. And we would be called in for that. And all of these, they may or may not send them through CT. They may just put them on the bed and treat them and worry about a plan on Monday morning when everybody else comes in. That is usually what happens. Questions on these three? No? No. Okay. So, other emergencies. Well, who's worked in a hospital at any time? Anybody? Or no? Okay. Let's see if we can figure this out. So you have emergency codes in hospital. So you call them, or the patient has a problem and they get called. So code blue. Code blue. Whoops. So let's do the codes. And what's that? What's code blue? Pardon? Okay. Cardiac arrest, usually. Okay, now there's some of the hospitals have several code blues. There's one which is called a rapid response, which means that the patient is deteriorating and they need somebody now, but it's not actually a code blue. So it would be called code blue rapid response. There's another one, in some cases, code blue stroke. Another one which could be code blue pediatric. So you get called, usually it's called code blue peds. So that the code team, everyone knows what I mean by a code team. Yeah? Anybody not know what I mean by a code team? You don't know? Okay, a code team is a team which is usually based in the ER, and their job is to attend any code blue that occurs in a hospital. It would consist of ER doctors, an ER nurse, a respiratory tech, several respiratory techs actually, and someone whose job it is, and usually it's a transporter, to get the crash card. It depends entirely on what it is. So you have to call these code blues, or in some hospitals it's doctor code, so it would be Doctor 66 or Doctor Blue or whatever it happens to be. And if you call the code blue, you have to tell them where you are, right? So if you're calling from the radiation therapy department, you call whatever number you have to call. It's usually a one-digit number, 6 or 9 or whatever it happens to be. And you say, I have a code blue, radiation therapy department, ground floor, A wing, or something like that. Because remember, in radiation therapy, not a lot of people know where we are. So especially the people who live over in the ER, which is probably in the opposite end of the hospital, you have to explain to them where you're going. So once you call a code blue, what do? Your patient, or it's usually a family member or a staff member, by the way, theoretically. So you have a patient in the middle of the floor. You've called a code. What do you do next?
So can we reenact it for somebody?
Sorry?
Nothing. I'll just.
So, you have a patient. You have decided that he has no pulse, he's not breathing. So there's 2 of you, so one person goes and gets the code blue sent. What are you doing? You're standing there like a lemon. What do you do?
Start CPR.
Start CPR. What else? Somebody else is going to do something else.
AED?
AED. Okay, if you have an AED, definitely. If you have a crash cart in the department, somebody goes and gets that because the AED is usually sitting on top. But if you don't have a crash cart, you get AED, and usually if you don't have a crash cart, you have an emergency tray, which has certain drugs on it. So somebody goes and gets the AED, someone goes and gets the emergency tray, and probably 2 people are actually doing CPR. What else? Whoops. What else? And, pardon?
Call doctor? I don't know.
Call the doctor, they're not much good.
Shouldn't they be there by now?
They should be. As soon as they hear a code, everybody appears. Everybody
By the
appears,
time I
but,
get that train, they should be there.
yeah. But the problem is that I remember asking one of our physicians, and he said, you guys know about CPR more than I do. So these guys are specialists. Probably the last time they actually did CPR was in their training. So you just forget about them. They'll just stand there and watch. I've already mentioned that perhaps the people on the code team don't know where you are. So there should be somebody waiting at the front door of the department, waiting for them to shove them in the right direction, or somebody by the elevators to make sure they come to the right department. Okay. So you're still doing CPR on this person. You hear the code team coming barreling down the hallway. What do?
You continue until they relieve you.
You continue until somebody comes up behind you and said, I will relieve you, thank you very much. I'm from the code team, please get out of my way. Or worse to that effect. Okay, so that's the code blue. Okay, next. What else? Code blue. What's the other most common one?
Red?
Code red. What's that for? Oh, come on, guys. Code red.
Oh, okay.
Fire.
That was too common sense. That was just, I was thinking.
Yeah,
too
too
hard.
common sense. Don't overthink it. Okay, so code red. So, you find a small fire in the chief therapist goes into her office and finds a small fire in the garbage can. So she goes over and she pulls the lever. And then she gets what?
Extinguisher.
The extinguisher and tries to put it out. If she tries to put it out, then that's great. The fire department's still coming. But if it's too big for them, what do we do then?
Evacuate.
No, not really. Not yet. Not yet. So, what do we do?
Close off the space, try and make it, minimize the exposure.
Close up the place. What do you mean by that?
Like the space, that specific area, try and
Okay.
minimize its exposure.
So, how do you do that?
Close doors, all the emergency.
Close the doors. Yeah, all of the doors are fire doors. So you close all of the doors, make sure there's nobody in the rooms. If the door is closed, you bang on the door and open it if possible. There's nobody there, close it and move on. Every door must be closed. Every door must be checked. Okay, you guys tell me, in your travels around this area, where's the nearest fire extinguisher? And where's the nearest fire pool?
Here?
In this area.
Usually they're at the ends of the main hallway.
Someone want to go out that door and out that door and you tell me where they are? Please? That's right. Tell me where the nearest fire extinguisher is.
I haven't seen a fire extinguisher at all yet. I've seen one here.
At the end of the hallway.
The end of the hallway? Yeah. Okay, thank
I
you.
don't see one that way.
There is one actually. And if you look at across the hallway, what do you see? The little thing that's green on the wall.
To the right.
Oh, evacuation.
Evacuation plan. Is there one across there too?
No.
No, there's one down the hall actually. So the closest fire extinguishers and the closest fire pools are right at the end of the hallway here. The fire pool is right beside the fire extinguisher on both sides. So if we get a call, and it will come through on the phone, by the way, that there is a code red first floor A building. What do we do?
Avoid a building.
Evacuate a building, yeah. So,
We are?
Yeah.
Oh.
so which way would you go?
The direction it's not.
Well, you don't know because it's on the first floor. You don't know where it is.
You take the stairs.
You take the stairs. Which stairs?
I would assume down that way. where
Closest
the doors are.
stairs.
Nearest ones.
The nearest one. So in this case, it would be those ones. You go down the stairs
And out the building.
and out of the building. You never come back into the building. And if it's you do not take junk with you. Do not leave everything behind, just get out. And I know that sounds weird, but yeah, I know. And we've done those several times and everybody takes their stuff with them, so. Anyway, so once you're out of the building, where do you go?
Far away.
There is
The parking
an
lot.
area where you're supposed to meet. Anybody know where that is? It's on the grass. You know where the employee parking lot is? That would be parking lot 1. And there's some green grass and trees beside C building. That's our area where we meet. Okay. Okay. So if we had a fire in E building, what would we do?
Still evacuate?
No.
Oh.
You don't want to evacuate until you're told to evacuate. E building is where? Yeah, think subway. That's E building, or the beginning of E building. So we would not evacuate unless we're told to. So we sit still and be ready to evacuate, but we do not evacuate. Okay, we'll come back to those. Okay, so let's see what we do with that. Anybody have any idea what this one is?
Infants,
Code pink. What? Infant what?
lost or stolen.
Lost child.
Okay.
Either somebody's walked off with them or the child's gone off on his own.
So is yellow like a general missing person?
No. It depends entirely on what the codes are. They change.
Okay. 'Cause I always thought yellow was like a missing patient.
In some hospitals it is. We're trying to just do main ones these days. And in this case, yeah, code yellow is a missing adult. So yellow would be missing adult. Okay. Code silver.
That's an old person, right?
Pardon?
I thought that was silver alert.
Active shooter. And we'll learn more about that later also. Okay,
Oh, we got like silver sneakers club.
code orange.
Hazardous material.
Pardon?
Hazardous material.
Hazardous, okay. So we'll have a hazmat incident. Okay, so what would be a hazmat incident in a hospital?
Food?
Oh yeah, that would be a wonderful one, yes, okay. So what else? What else could be a hazmat incident?
Like a gas leak.
Hmm?
Like a gas leak.
Gas leak, that would be more a fire thing, not hazmat type thing. Think about the chemicals that are used in a hospital. What chemicals are used in the hospital?
Bleach?
Hmm? Chemo? It could be a hazardous incident, yeah. The things like they use in the lab, there's some chemicals that they use in the lab that might be a hazmat incident. There's, for each chemical, there has to be a sheet, which is called an MSDS sheet. And that tells you what the chemical is and what it does if it touches your skin or your eyes or whatever it happens to be. And if you call a hazmat incident, then who comes? You call a code orange. Who does it go to? Fire department. Now these fire guys are coming in. They want to know what kind of chemical it is. So you have to dig out the MSDS sheet and hand it to them and say, here you go. Because they don't know. Okay, let's try this one. Bomb threat. Yep. So what do you do if you get a bomb threat? If you
Take
pick
down
up the
as
phone and somebody says, I've planted a bomb, due to go off in 2 hours.
Take out as much information
What do
as
you
you
do?
can. Get as much information as you can.
Keep them on the phone, get as much indication as you can. Like what, for instance?
Name, location of the bomb.
Their name, sometimes they'll actually give it to you.
Location of the bomb.
Location of the bomb, when is it due to go off? Why did they do it? The other thing you're listening for is, are they male? Are they female? What kind of age do you think they are? Do they have any weird accent? Is there anything in the background that you hear so that you can tell the bomb squad when they arrive, or the police when they arrive? But the thing about it is that you need to maintain your cool. You don't think, hey, oh. Yeah, you don't do that. Having had one done, having actually had one, a bomb threat done, it's pretty scary to say the least. And my bomb threat actually went off. But anyway, so apart from that, if you can find out where the bomb is, then obviously you would evacuate that area. But the chances are maybe that they tell you it's somewhere and it ain't. It's somewhere else. So what you need to do is everybody knows their own little area, right? You're working in an area, for example, in this classroom. You know whose backpack all of these are. You know whose purses all of these are. If there's something that doesn't fit, what do?
Report it.
Yeah, leave it where it is and report it. Okay, let's try this one. Code Brown. Anybody get any ideas?
Like a chemical spill, something like that?
No, that would be a hazmat. That would be a code orange.
What color do you want?
No. No. Definitely not. Good thought, but no.
Oh. Explosion, everybody on the floor is explosive diarrhea right now.
Severe weather, I'm sorry. This is used sometimes, not very commonly, but it is used sometimes. So severe weather, if there's a tornado being spotted and it's heading straight for the hospital, then that would be called. Code white. No? Now this is different from silver. This is just somebody who's holding somebody hostage. It could be the same person, but we haven't seen a weapon, so it's code white. And there's another one, which is this one, code gray. So this is a security alert, sort of all security, because it is what they call a combative person. So this could turn into code white, or it could turn into the active shooter. But for the moment, it's somebody who may be in the ER and he's drunk and he wants to fight with the security guy and the cops are called, that would be a code grey. So if you hear code grey called, then you'll see all the security guys disappear and go down to wherever they happen to want to be. And here's another one. This is the last one. Green.
Emergency evacuation.
No, not really, no. Sometimes it is, but this one, who did I put that in?
So I've seen it.
Oh, yeah, in some cases it is.
Do we not have one for missing elderly or, special needs?
No, that's either a child or, no, that's either a child or an adult.
What was that last one, green?
Green, mass casualty or disaster. So if a train overturns or two buses, fully packed buses collide or something like that, then that would be a mass casualty.
I thought there was a purple.
In some cases there may be, but I was just picking out the ones which were
Universal?
used a lot of the time. Okay, so let's start with the fire. So I've got a few, and I'll leave the good ones till next week. Yeah, don't go there. Okay, again, this is OSHA. So this is kind of old, but it gives you an idea. So 1.45 million fires in 2008 and 1,348,500 in 2009. Over 3,300 civilian deaths. Decline in both in 2009. 15.4 million in property losses. So exit routes, emergency plans. So, Triangle Fire, 1911, New York City. Deadliest accident in industrial building fire in the nation's history. Killed 146 workers. Many jumped from upper floors. Killed so many because a lot of the fire doors were left open. There were fire doors at that point, but they didn't work as well as the ones that they have now. And a lot of the windows were locked. In 2010, garment factory near Dhaka in Bangladesh. 30 died, 100 were injured. And all of the exits and windows were locked. So exit route. Continuous and unobstructed path of exit. Travel from any point within a workplace to a space of safety. So again, you're out there or you're out that direction. Why not use the elevators?
We'll stop.
Maybe. What else? If the fire department needs the elevators, they have a special key, right? So they need to get into those elevators. Not so much because it's only 3 floors, but everybody takes the stairs. What if somebody was in a wheelchair? What do you do then?
Pick them up.
You have a mass evacuation out of the whole of building A is being evacuated. And you've got one of the nursing supervisors who's broken a leg and is in a wheelchair at this point in time. What do we do?
Roll her down the stairs.
Who does?
Multiple people.
Okay,
You could actually probably go like backwards and bring him down.
and then you fall and break your leg.
Well, if you have multiple people, maybe not.
The idea is that you don't.
Leave him to die.
The way it works is that you leave them in a specific area where the fire department knows where to go, and they will take care of them.
Oh, that's scary.
I know.
No, in all seriousness, that,
We'll see it in an hour, hopefully.
in all seriousness, that's what happens.
That's so sad.
You cannot, if they can walk on their own with help, then that's fine. If they're confined to a wheelchair, then there's designated personnel in the building who are designated to help anyone who is disabled. And they will come and help. And the people in wheelchairs know this. So, yeah. It may sound hard-hearted, but that's the way it works. And everybody gets out that way. Okay, so exit access. Part of an exit route that leads to an exit corridor that leads to a stairway or exit. Have you noticed that the exits are all light? They're all lit? And it says exit. Why is that? Why are they all lit?
Find them easier, if it's dark and the lights go out, they're supposed to be on the
If-
generators.
Yeah, if there's dark and the lights go out, yes. Not so much the dark,
Smoke.
smoke. So if you have a smoky hallway and you're trying to get to the exit, you will see that through the smoke. What do you do if you have a smoky corridor? You just keep walking? What do you do?
Stay low.
Crawl. You crawl. Smoke rises. You keep low. Exit discharge, the part of the exit route that leads directly outside or to a street, walkway, or refuge area, or an open area with access to the outside. That's what these doors are. They'll take you down to the first floor and exit you out onto the walkway. Exit routes must be permanent. An exit must be separated by fire-resistant materials. What are the fire doors here? Is there fire doors here?
Well, I think those are fire doors leading to the stairs.
Yes, they are, but there's another set of fire doors
I don't know what those are.
halfway down the hallway.
Oh.
They're actually usually open. If you go up this hallway, either hallway, and you'll notice two doors sitting open, and they're magnetized, so that when a fire alert is given, the doors shut completely. And they will not stay open until somebody actually keeps them open. The engineers will hit a switch somewhere in maintenance to keep them, to magnetize them again. And please do not leave them, do not keep them open by any other means. Openings to an exit must be limited, so there's really only one exit here, and there's one exit down here. So if you went down that way, how do you get to the outside?
Right?
To the right? Okay. What if you turn left?
Get out that way.
Whichever's closest, you want the closest. So if we were in the radiography lab, which door would we use? Yeah, the one on, just outside there.
Behind all the tables. Underneath back, right there in the back.
Say again?
Behind all the tables, the one closest to the hallway.
Okay, yeah. You could use that. But no, I'm talking of exit doors to the outside.
Oh.
Number of exit routes must be adequate. So if all of these classrooms were full, so you have how many exits, ways, how many ways out do you have from here? Out to the front, out to the outside door, or the outside. How many exits? 4. You have one this way, one that way, one that way, one this way. Exit discharge must lead directly outside. Exit doors must be unlocked from the inside. You'll notice if you go out those doors, you can't get back in. You know that, right? Okay, you can't get back in. So those doors, that one and that one, are emergency doors that will lead you straight to the outside, but you cannot get back in to the building. So if you want back in, you have to go all the way around and come back in the other way. Or come in through the first floor. A side hinged exit door must be used. What do they mean by that? Side hinged exit door. Do we have a side hinged exit door there? Yeah? Yeah, we do. Good. Ceiling at least 7 foot 6 inches high and 28 inches wide. And there's your exit sign, and it's lit up. So there's an exit. Notice nothing is really stopping it except those chairs. Theoretically, the chairs shouldn't be there, but you have an exit straight to the outside. At least 2 exit routes must be available in a workplace to permit prompt evacuation during an emergency. Exit routes must be located as far away as practical from each other, so that if one exit route is blocked by fire or smoke, employees can evacuate using the second exit route. So if you get out of that door and you see smoke, if you open that door and you see smoke, we just continue.
No.
Okay? So you come back in and say, no, this has got smoke. Now it doesn't matter, it may just be smoke, it may not be fire, but there's still smoke. So you go out the other one, which will be that one or that one. Okay, reporting a fire. How do we report a fire? We'll say in a hospital or in a cancer center. How do you report a fire? Do you come around and yell, fire?
Pull the lever on the wall.
Pull a lever on the wall. Yep. And then? Normally what you would do is you would also have, remember we were having a separate number to call for a code blue. You'd also have a you have a number to call for code red as well. Just to let the switchboard know that there was a fire in whatever happened to be. Normally with these things, you pull the lever, it goes straight to the fire department. But you have to let the switchboard know as well. So then what do you do? Depending on where it is. So we'll go back to our little scenario about the fire being in the chief therapist's office. So you've got her out, or she's got herself out. She's closed the door. So her office is away from the treatment machines. So she's pulled her lever. She's tried the fire extinguisher. Too big for her, so she shut the door and left. Which reminds me, everybody know how to use a fire extinguisher? Has anybody ever not used a fire extinguisher? You've never
Pull,
actually?
aim, sweep, something.
I think there's.
Has anybody been
isn't
taught to use a fire extinguisher?
Isn't there a
A
pin you have
long
to
time
pull
ago? Okay,
On the ship, you are your own fire
So-
department.
what do you do?
Pull,
There is an acronym. Right?
pass.
Pass, yeah. So, pull, what are you pulling? The pin. A,
Aim,
aim, S. What's the other S?
Squeeze and sweep.
oh,
Squeeze.
squeeze.
So you have a fire extinguisher, right? You have a pin that you pull, which is P. You have A, which is aim. So where do you aim?
On fire.
The bottom of it.
The base of the fire. Always at the base of the fire. You aim base of the fire, you squeeze the trigger, and then you sweep. Okay, so you've got this fire extinguisher. You're pulling the trigger and you're doing this. Not this, but this. Okay? And that should put it out if you can. If, however, you cannot get it out, you close the door and wait for the professionals. Once you've used the fire extinguisher, what do you need to do?
Probably just give it to them.
Pardon?
Have it replaced.
Have it replaced. Well, yeah. Why?
So that you can have
Yeah. How often are the fire extinguishers checked?
annual.
They're supposed to be on a schedule.
Yeah, they're usually annually. And if you notice them, there's usually what looks like a luggage tag, and it gives you the date when they were checked.
I
And it
just
should be
realized
full.
last night that I have one in my apartment, under my sink. No one ever told me, I didn't know it was there,
Mm.
but it's good to know.
Yeah, it should be checked once a year and it should be full. Because if it's not full, then what do? Right? So, emergency evacuations. So if they're doing evacuations, you've still got patients on the bed. What do? Do you stop the treatment? Or do you continue?
I would think you would stop.
It depends on where the fire is. If it's close to you and the fire marshal, there's usually a fire marshal in the hospital. And as soon as there's a fire somewhere, he beels it over to wherever it is. If he says you need to evacuate now, then you stop your patient's treatment and you get them out. However, if it's not close to you, then you can finish your patient's treatment and get them out. It may be they need to put a gown on and come outside. You don't have time to, you've got time to complete the treatment, but you haven't got time for them to change. So you get them in their gown and off you go outside. Depending on what kind of weather it is, you might have to do that. So
If the fire alarm's going off,
mhm.
I feel like the patient will be kind
Right.
of freaked out.
No, because remember,
Like,
remember, all of the patients who are in the waiting room have gone. They've gone out. These rooms are soundproofed.
so they really.
So unless you have the door open, they can't hear.
So there's no fire alarm in the room.
No,
Okay.
because there's always staff members with them. If the door is open, you can hear the fire alarm going off. But if the doors are closed and you're actually treating the patient, they have no idea what's going on
That's
outside.
real sound.
That's still very unsettling, like just, I can't imagine like being on the couch, getting ready to have my treatment.
But you don't know.
The door's not open while they're doing like the setup and
Oh,
stuff?
yeah,
Yeah.
but no, I'm talking about when the door closes
Right.
and somebody pulls a fire alarm when the door is closed.
So if you haven't started, would you leave, or would you just wait and see?
If you
what
haven't started, then you would get the patient off.
happens? Okay, but if they're like mid, like,
Yeah,
so
if
people
possible,
are fine.
if possible, you can complete the treatment, but if it's not possible, then you go in and you say, okay, Mrs. Smith, we've got a fire alert, and maybe nothing, but we want to be safe, let's get you in a gown, and off you go. Okay, employees who remain to operate critical plant operations before they evacuate. So that might be us. If we are trying to finish the patient, then we would finish and then hightail it out with the patient to wherever we need to be, to our area where we're all looking at each other. Accounting for employees and patients after evacuation. So everybody's got out of the building. How do we know if there's anybody left in there?
You gotta do like a walkthrough.
Pardon?
Do like a walkthrough. Make sure everybody's out.
Once you're out, you don't go back in.
I mean, like the last person.
No. No.
Where I've worked, you've had somebody that was assigned the official person that was the last person out, that had to check all the rooms,
No.
make sure everybody was out.
What you do is if you're in a fire situation, as you leave your area, you shut all the doors and it's your responsibility to check if those doors if there's anyone behind those doors, and if there's not, to shut them. There should be no door in that area which remains open. And if the doors are shut, that means that everybody is out. That is your responsibility as you come out. So what you do, and never, ever, ever go back into a department once you've been evacuated. Even if you think there's somebody left inside, you do not go in. That is just foolhardy. So, there's usually somebody whose job it is to check everybody's name off. You know which patients you have. So you can say, okay, yeah, I have Mrs. Smith, or I have Mrs. Brown, or Mr. Jones is over there, or whoever it happens to be. So if we had a fire here, my job would be to shepherd everybody out and make sure that nobody is missing. So I have 2, 4, 5, 6, 8, 9. I have 9 people. So I have to make sure that I've got 9 people once I get to the assembly point.
What if someone was in the bathroom?
Then you get them out. No time for modesty, I'm sorry, but you get them out. No, in all seriousness, no. If you have somebody in the bathroom and you know they're in the bathroom, then you go in and you yell at them and say, look, I need you to come out now. As I said, there's no time for modesty. If it's one of the guys, then you bang on the door till he answers. Or go in, don't care. You make sure that everybody that you're responsible for is out. Okay. So the emergency action plan must be in writing, kept in the workplace, and available for employees to review. However, an employee with 10 or fewer employees may communicate the plan orally to employees. So here you have your assembly area. You have a primary exit and a secondary exit. So you have actually 3 exits. And you all should meet at the assembly area up here. So that's what the evacuation plan is on the wall. Employee must designate and train employees to assist in safe and orderly evacuation of other employees. So, here's your other one, race. So rescue, alarm, contain or confine, and extinguish or evacuate. So race is rescue. So you make sure that everybody is out of whichever room the fire is. You pull the alarm, and then confine or contain. So you would all go to the other side of the fire door, get out if necessary, or extinguish the fire. And by that time, the fire department's arrived. The number of, we had, not last year, year before last, we had 4 fires. And they were all, 2 of them were little bitty fires that somebody had left a coffee pot on and it started to smell because it was burning. There was no coffee in the coffee pot and they'd left it on the heat. and there was 2 false alarms. But we all got out there, and the fire department came over and they looked, and the 10 minutes they were gone, which is fine. Okay, emergency plans. So fire, toxic chemical release, the only thing that we would be worried about. Now here, we have a lab just across the hallway there. And they deal with some chemicals, so we have to be careful on that. So we don't get, I noticed they didn't do earthquakes. We don't get earthquakes very often around here, but we do deal with hurricanes and tornadoes and some floods. The good thing about hurricanes is that you usually give you some warning, right? Do you get warnings with tornadoes?
No. Maybe like a
Sometimes.
few minutes.
Sometimes. Anybody been stuck in the middle with a tornado? Yeah. It's scary. So where in the radiation therapy department, where is the best place to be in, say, a tornado?
Probably the room, the treatment room.
The vault, yeah. It's basically a concrete box. And it's actually a good tornado shelter. Good earthquake shelter too, but a good tornado shelter. So fire prevention. List all major fire hazards, proper handling and storage, potential ignition sources under control, and types of fire prevention equipment necessary to control each major hazard. So who can tell me the different types of fire extinguishers? Did you know we had different types of fire extinguishers?
I know there's like K is like kitchen, I think. Isn't K like for kitchen?
There's fire extinguishers for paper. The ones that we have are CO2 fire extinguishers, which will take care of most things around here. There are special ones for gases. There's a special one for electrical fires. For the moment, everybody should have a normal type red fire extinguisher at home. And notice we also have sprinklers. So you're liable to get wet before you get anything else. They've never come on, thank goodness. So, is that a good fire exit?
No. It's blocked.
It's blocked. What's it blocked with?
Cans of paint left open.
Combustible materials.
Yeah, of course, it tells you there. Okay, so it's hazardous type materials. So they should, one, they shouldn't be lying around, and two, they should be where they are, because presumably this is a fire door, and you should be able to get out that door. You need to know the correct place to direct employees, train and workplace layouts, and alternative escape routes. Aware of handicapped employees who may need extra assistance, check all rooms and enclosed places for employees, and account for or verify that all employees are in the safe areas. Okay, so I'm going to show you a little fire video. Not a big fire video. The big fire video is going to be next week. And I'm going to, This is from Australia. And it shows you how easily things can happen. This will work.
Put it up, Mr. Hilton. They're your lungs when you go home, but while you're in here, they're ours.
I want your white bed. I want your white sleeping immediately. Can I take my tea? Of course. On you too? Hi, children. How fast was the bus going, Samantha? I don't know. We just came around the corner and smashed. That's all I can remember. Oh, I think it's time we all went to bed. Come on, under the covers. Come on, into bed. How you get here?
Is she breathing comfortably? She's beginning to settle.
This is an old one, as you can probably tell.
Right, my favorite.
You know, I lost 2 pounds last week.
Oh, God, one way to have you.
One leads to another.
One? You've got more than 11 down up that sleeve.
Got some money to look.
The healer takes 2.
I'd really like to go overland through India. See all those places you never see otherwise. I'd like to go to Norway. John said it's beautiful.
Nurse.
Hey, sister, why don't you give a bloke a treat and come up and see me sometime?
What took you so long to ask?
No, no, come see me anytime. I'm in most nights.
Go to bed, Mr. Hilton. Sweet dreams.
Oh, yes, sure.
What is it, John? Poker.
Come and sit in for a few hands. Bring a little sunshine into your life.
Dutch. You two should be in bed. Please don't make it so I have to report you.
Why should I bother? You will anyway, won't you? As soon as the moon strikes you.
Please.
Right. Exciting again. Fools rush in.
What? Excellent.
Here's your attention, Marco. Go down to the General Hospital, Kalani Street. Marco, General Hospital, Kalani Street, Roger.
Careful, guys.
Hi, darling. I'll wake you up now, okay? Oh, well, we're just gonna get you up, okay? Can you help me? Oh, sure. We're just gonna go for a walk down the corridor. Oh, okay? Yeah. Come on. You all right? Of course I'm all right.
Can I lick you guys?
For God's sake, remember your training. That's right.
Check the fire stairs. John, see what the situation is with the fire in the basement. Alan, check the woods upstairs. Make sure everyone's getting out all right. Where's the hospital superintendent?
Just had him on the phone. He's on the way.
Do you know how the fire started?
I don't know. He's in the basement up at the 8th floor.
The 8th floor as well, eh?
Oh, that must be good. Thank you.
Sister?
Take your breath.
What the hell's going on?
I'm gonna be here in 20.
Sister?
We're just going to put you in your chair now.
Yes, all right, yes, but don't be careful, won't you? You're probably don't care. Where's the satisfaction? It's all right.
Hospital secretary. What do we do? Get everybody out. There's no other option, I'm sorry.
Just keep moving towards the stairs.
Take it easy, down the stairs.
Nurse.
Thank you, nurse.
Still Johnson?
Behind us.
No, we're gonna get you out of here, and you've got to keep calm. Nurse, shut that bloody door. Bring her with you, nurse. Keep going, keep going.
But how long have we got? I see. The main stairway's impassable and the fire stairs cut, but they expect they can get it under control. We've got to get everyone out that way. Everyone. We've got about a minute and a half for more oxygen. We'll have to get them all onto manual.
We can't do it in a time.
No, we can't.
Who do we say?
Take that patient first.
Quick message to control. There was more breathing apparatus. Turntable ladders. I want 4 lines in, 2 lines out. Getting away from us. 10 minutes, that's all it takes.
You have to go up. The fire stairs are cut.
We'll take care of this.
Right. Up you go, kids.
Children, there's a small fire in the hospital and we're going to
Do
get
exactly as you're told, you'll be all right. Right, kids, I'm going to clear a path for us all to get out. You stay here with Sister till I get back, all right?
Don't do anything silly.
No worry.
Has anyone seen Mr. Page? Has anyone seen
You know any good terms?
None that spring to mind.
Sure. Hospitals don't put down.
We shouldn't be up here. Fire burns upwards.
So much of it.
It burns upwards.
Yes, it does. Why didn't anybody tell us what to do?
It looks out of control on the 8th floor, communicating itself to the 9th. Right. I'm going outside.
Interesting, isn't it? I haven't seen a good fire in years.
No time no see.
Yeah, you know the holidays. You and I can get out maybe with a bit of luck.
Not there.
No. Take it up as high as you'll go. Go and reach the 9th floor. Just one more floor.
Keep where it reach. Try to get to the stairs and keep out of the smoke. If you can't avoid the streams in this one.
Now, children, I want you to listen to John.
Okay. Now, we're going to keep low, down on our hands and knees because of the smoke. We're going to breathe slowly and through our noses. And no talking. Got that?
Yes.
Right. Okay, let's go. Okay, everybody? Right, now keep close to me. Right, now keep close.
Come on, children. Keep down.
So, we're going to have to go up.
John, you're ahead of me, and hero. Come on.
Come on, I'll catch you up. Get through the next floor, to the fire stairs, and we'll be all right.
I'd rather you came with us.
You and me both. See you later, all right?
Come on, children.
Fire stairs are now clear. Move quietly to the stairs. Do not panic. I repeat, do not panic.
Sister, the stairs are clear, we can go down.
What happened?
There's one more child in the hall. I'll get him.
Stay where you are.
I'll be all right.
Come on, move down. Michelle!
I know.
The fire is now 31 minutes old. 100 firemen from 12 stations will fight it. It will burn for 6 hours. 9 people will die.
Still so high.
I'm sorry.
That was a dramatization. Very good one, no? So we all saw how the fire happened. As I said, it's an old one, but it still gives you an idea of what could happen. Next week, I'm going to show you an actual fire, which was in Hartford, Connecticut. I think it was 1960 something, but it changed a lot of what we know today as fire safety in hospitals. Let me do something else while we've got some time. What do you know about active shooters? And what we should do if there's an active shooter in the building?
Turn off the lights, lock the doors, stay away from the doors and windows.
What's that called? What? Why?
Out of view, the windows on these doors.
Yeah, so you have to make sure. What is that called? It's called run, hide, fight. So the idea is that it used to be, if you had something like an active shooter, everybody hid, right? Now we don't do that. The idea is that we run, hide, and fight, or run, hide, or fight, whichever you can do. If you can evacuate, you evacuate. If you can't evacuate, you hide. If somebody gets in, then you fight, because they're gonna shoot you if you don't. So these doors lock, both of them, right? What about that door? Try and open it. It's locked from the other side. So unless the active shooter gets in through the EMS area and gets in that way. So we'd have to barricade that door, okay? So it's called, the thing that we use here is called ALICE. Has anybody heard of this acronym ALICE?
Remember what it stands for, but I didn't remember.
Yeah, so ALICE, actually wrote it down. ALICE stands for alert, lockdown, inform, counter, and evacuate, not necessarily in these terms. So let me, let's see here. Let's see if I can play the video that I'm looking for. Whoops. I'm just looking for one that,
Okay, I just want you to stay in the line with me. I need to know what's going on. Okay. Okay? I am on the floor. Okay. You got the kid there? Yes, I am just at the library on the floor. Is there any way you can lock the doors? If I was coming in from out there, I'm a little bit. It's right outside the library door. Okay? I don't think I'm going to go out there, okay? You're going to call me my I got three children. Okay, we got it, okay? We're going to go to the door. You just don't open the door, okay? I've got the kids on the floor.
There's somebody downstairs with a gun! Somebody just got shot!
Somebody get the bell! Watch out, watch out!
You said there's a shooting in Nichols Hall? Can you actively hear gunshots?
He was downstairs in the lobby. He shot somebody.
Can you describe what the shooter looks like?
A white male. He had a big coat, black or blue. He had facial hair. I don't know what way he went.
White male, okay.
I ran upstairs. We're in a classroom right now. We have an instructor with us. We barricaded the door.
Okay, can you stay on the line while I get officers en route?
Yeah.
Stay tall units. Can I have you en route to Nichols Hall for shots fired?
Suspected. White male with facial hair, black jacket, black pants, black eyes, and then a lobby. Repeat, Nichols Hall for shots fired.
Okay, and what is your current location?
Upstairs in 301.
I'm gonna ask that you stay on the line with me. I have officers en route. Please continue to barricade your space and be prepared to defend yourself if necessary.
so why is he doing that? The bell to run the door?
Keeping the door closed.
So the door opens which way? In. So the idea is that you wrap something around there so it stops the hinge from opening up. What did I do?
Yeah, you went to the next video.
I went to the next video.
Yeah,
Last. Okay. Let's do that. Okay, there we go. Okay.
Go get help! Somebody get help! Hold on, help's on the way. Stop! Get help! Check his box.
What you have just seen is a proactive approach to survival in a violent intruder situation. Traditional response to violent intruder events has focused primarily on lockdown-only principles. Analysis of past events has taught us that survival may depend on utilizing several options, to include, but not limited to, lockdown. Under stress, we default to our level of training. We must train our brains to react to various crisis events, allowing us to respond proactively and increasing our chances for survival. The shooter has a plan. You should too. This training will aid you in developing that plan. ALICE is a concept which allows those who find themselves in deadly situations the opportunity to make informed decisions about how they respond to that event, given the available information. ALICE is an acronym to help you remember what to do. Your response may or may not occur in the order listed, and all options might not be necessary for every event. Keep in mind, each person or group will respond differently given their proximity to the crisis, and responses may change during the duration of the event. Alert. If you are in a safe place, use any means available to alert the police. Stay on the line if at all possible. Give clear and accurate information about the location, suspect, weapons, and injuries. Alert others of the danger if possible, again using any means available to you. Lockdown. Lockdown is still an integral aspect of active shooter response. If you are in an area that can be secured, do so. Lock the door if possible and use other means to barricade and secure the door. Stay clear of windows and silence phones. Even if the door is secured and barricaded, make a plan on how you will respond if the shooter makes entry into your area, and be ready to attack if necessary. Inform. Continue to share information with the police, those around you, and others throughout the entirety of the event. Information is fluid, and your response must be as well. Counter. If you come in contact with the shooter and you cannot escape, make yourself a hard target. Move, react, throw objects. Do not become static and passive. Improvise defense. Use anything and everything to distract or disable the shooter. If possible, employ multiple people to swarm, secure, and disarm the attacker. Put the weapon in a trash can or out of sight. When the police arrive, they do not want to misidentify who the shooter is. Remember, if you encounter a shooter, it will be a fight for survival. Don't hesitate. Most active shooters are not expecting resistance. Evacuate. If there is any safe way out of the room and building, use it to escape. The goal in any crisis situation is to remove yourself from it and create as much distance as possible. Know your surroundings, exits, escape points. Don't use your car to evacuate. You do not want to cause traffic jams that prevent police from getting to the site. The most important message to remember is, do something. Your goal is to survive by any means necessary. Train your brain and be proactive about your survival.
Okay. Okay, so does anybody have the app on their phone that is FSCJ Safe? Everybody should have it. So it's on Android and or iPhones.
It looks like this.
Yeah, just like that. This is where you would get text if something happened, whether it's because of a hurricane coming, or the bridges are closing, or there is a fire alert, or there is an active shooter on campus. It will come, if you're here in the classroom, it will come through the phone here. It will also go onto your phones. It will also go onto your emails. So it's a good thing to have. And the other thing you can do is also, if you're, obviously with us, we don't come in the evenings, but if you're here for some reason in the evening, you're in the library or something, the security will actually walk you out to the car, or they will, there's a little app on the part of that app is to tell security that you're going to your car, and you can let them know when you get there safely. So it's really a good thing to have, and it's free.
There's also like a emergency hotline phone number, so like I saved that in
Yeah.
my contacts also.
Yeah, yeah. So there's lots of different things you have to choose your campus. But it's a really good system. When the hurricanes, when they were threatening to close all the bridges, I got a text on the app, I got a text on my actual phone, I got a text on the app, I got an email text, I got all sorts of things. So it's a really good system to have. Did everybody see the notification that there was a weird guy on campus on Friday?
I saw posters on the door.
On the doors, yeah, I didn't realize that. Well, it was somebody who was exposing himself.
What? It was weird because it said he was laying down.
He was laying down, exposing himself in one of the parking lots here at lunchtime on Friday. Yeah, I think it's a case of, point and laugh or something, but anyway, so it was on the security thing, so. Why? Goodness knows, so. Anyway, so Alice, actually, what you saw here, the security do Alice training. So if you feel that you want to do Alice training, you can certainly contact security and they will do an Alice training for you. I've done it, it's really good fun. It's very interesting.
Let's all do it at the same time.
Yeah, it's actually very instructional. And they take you across to everybody knows that there's a police college over here, right? Everybody knows that they train the sheriff's office over here. So they take us across there and use what they call the search house to do some, so you can actually barricade yourself. Pardon?
You should make that one of our Monday classes.
I'll see if security chief will do that for us. But meanwhile, I've got some videos that might help you. So, in the last little while, so if we had an active shooter in building A on the second floor, we would lock these doors, get out of sight, and you have to remember there's two doors here, so you have to get outside of both of them. So it would be sort of over to this wall. Lights go off. What else do we need?
Turn off phones, phone ringers.
Turn off quiet your phone. What else? What happens if he gets in? With what?
Kick him in the groin.
With what?
Throw with things at him.
Yeah, so book bags are always good.
Yeah, hydro flask.
That thing is always good.
In high school, they always told us to put our backpacks on backwards, and then while we're waiting, so they're blocking us in case they that girl that was just sitting there.
Because you usually have textbooks in your backpack.
Yeah,
so
and it would protect you, but if you needed to throw it, you could.
Yeah, okay, yeah. Unfortunately, where the fire extinguisher are, you probably wouldn't get to it, but this thing is marvelous. Look at the size of this thing. I mean, that's a weapon.
I was at NAS Pensacola during the active shooter last year, and I had that, and it was full of water. I was I'm ready.
It's heavy.
I'm ready.
It's heavy, yeah. So, I mean, you could use that to throw at somebody, or you could use it as a club. And if you had a fire extinguisher here, or if you could grab a fire extinguisher, what would you use that for?
Hit him.
Hit them?
Or extinguish.
Spray and hit.
Hit them and, you know, use it. It's CO2, guys, use it as a fire extinguisher. That would shock the hell out of them.
Hit them with it on the floor and then
And
just
hit them with
extinguish
it,
his
yeah.
face.
Yeah, just spray it, that hurts.
So
Yeah.
what do you do if you manage to get them down onto the floor?
Take the gun away from him.
And
Step
where
on
do you
his
put the gun?
face.
Trash can. Keep it out of sight. Don't get caught with it in your hand. Okay? Now, there's a lot of retired military or ex-military people on this campus. I remember somebody saying to the security chief, we were having a little talk by the security chief, and they said, "What's your stance on carrying weapons?" And he said, and I quote, "I don't want to know. But it's on your own head if you use them." So, take that for what it is. If you have mace, you could use that. But I don't want to know.
If you have both though, you have to use the mace first because it's non-lethal.
Yes, oh yeah, yeah. But in all seriousness, if 4 or 5 people manage to get this guy down and sit on him, we can keep him controlled for as long as we need to until the cops arrive. And remember, the police are not there to actually make sure that everybody is safe. They're there to capture the shooter. If there's people lying and they're injured, the police will go right past them. They're there to get the shooter. And then after they get him or her, for that matter, they will help the injured. Or the EMS guys will come in and help the injured. But the police are not there to help the injured, they're here to get the shooter. So think, what could you use to barricade the door?
Chairs.
Chairs?
Tables.
Tables?
That.
That goes on wheels.
Yeah.
But I don't think there's locks on it, so that wouldn't be an awful lot of good.
Open out.
It's kind of heavy.
Pardon?
These doors open out.
These doors open out, yes. But they're locked.
Yeah, I know.
They can be locked.
I always wondered when I taught whether, all my doors always had glass in them, and I always wondered, was it bulletproof glass? And then I thought, no, they're not spending money on bulletproof glass.
No, they're not.
So really, man, that's a lot of glass.
Yeah.
They could
But
reach
it's
in.
tempered glass, so they'd have to shoot it in.
Yeah, they'd have to shoot it in,
Yeah, well, he can't get in here, so.
But then if you shoot it in, then you could
Yeah, true, I guess so.
yeah.
play devil's advocate here. If you shoot the glass in, you can put your hand
Right,
in and
I mean,
open the door.
there really is no way to keep one out
So,
if somebody wants to come in.
You
Well,
need,
we'll all be ready, standing
Yeah,
there with
you need
guns.
to have something that you can barricade, even though those doors are locked. You need something to barricade in. So the tables,
At least to block the way, slow them down a little bit.
well, this is it. If he's got a barricade he has to go through, he's not gonna wait, he's gonna go and find somebody else. The stretcher, it has locks on it. You can put that against it. And you can throw your water bottles, throw your books, whatever it happens to be at them. Through the skeleton. Yeah, that would freak him out, wouldn't it?
It would definitely distract him.
Yeah.
I think if we.
But if, this is it, you have to distract him, especially if the scenario that you saw, that last one, he had a handgun. What if he had an AR-15 or an AK-47 or a shotgun.
Yeah, we wouldn't have a chance.
The first couple of people wouldn't have a chance, but the rest of us
Yeah.
could.
Who's gonna be the first couple though?
Either me.
Well, if everybody is over to the side, you've got barricades up on each door, you should be reasonable. And you know, just make sure your book bags are
Hold the
heavy.
table and charge them.
Yeah.
Yeah.
Make sure your book bags are heavy and throw them at them. I mean, the books that we have, guys, are heavy. All you need is distraction. You're not gonna, you don't want to necessarily, well, you do want to hurt him, but you don't necessarily want to, you want to get him on the floor and the weapon out of his hand. That's what you need to do if it comes to that. Okay, so that's my preaching done for the day. We will continue this next week.